It's very hard to give a lecture. It's very hard to give a lecture after lunch. Everybody's gone home, taken out. So I have to talk to you guys. I appreciate those guys who just came in and participated in my conference. In my country, one of the most common aesthetic operations is rhinoplasty. So we have so many patients, and patients have so many questions. The people ask us, why I'm not like that? Why she is not like me? Why my nose is like this? My sister is not like me. We have so many questions to be asked. One of the questions they ask us regarding the complications of rhinoplasty. And rhinoplasty, in fact, is one of the most difficult part of the aesthetic surgery because the compliance of the patients in one side and the expectations of other people surrounding that patient, another side, makes it so hard for plastic surgeon to please the patient. So patient has so many questions. One of the questions they frequently ask us regarding to plastic surgery, doctor, I have smelling difficulty. I cannot smell things well after the operation. What can I do? Then you say, okay, wait. Their next question is when? And my presentation is to answer when. The smelling factor, the smelling mechanisms of the patients after rhinoplasty will recover. Smelling factor is one of the important senses that the human beings have. Belong to cranial nerve. One goes to the brain and gives us pleasing effect, sometimes non-pleasing effects. It's one of the part of the needs for human beings. So if you go to the blogs and internet, there are so many patients asking this question. It says, doctor, I have been 4 days post-operatively, I have done my rhinoplasty. Now I cannot smell things well. And the doctor answers, don't worry, everything will resolve. When? We don't know. The research that we did with our colleagues to answer this when question, the timing which smelling or olfactory function recovers after open rhinoplasty. Most of the patients we chose were based upon open rhinoplasty. My colleagues and I, we decided to select the patients based upon the inclusion and exclusion criteria. We chose patients based upon the gender identifications, men and women, and also the basic health of every individual which they were participating in our study. Our study, of course, was not controlled. Case control was not CTR. Case control study was a cohort. That means we chose those patients from the time of the before operations, peri-operatively, 1 week, 6 weeks, and 6 months, 3 weeks, and 6 months post-op to assay their olfactory functions recovery. For your sake of review, we remember that olfactory neuroepithelium locates upper end part of the olfactory nasal cavity. If we find the nasal cavity like this room, and the surgeon stays in the coming door front, the neuroepithelium is this side of the nasal cavity. So that means if we do the operations from that beginning of the room, there is no sense to touch any nerve from this part of the room, which is the nasal cavity. They are chemotaxic, not nociceptors. They are stimulated by some chemical substances which create odors for the patients. They pass through the nerve endings, 15 to 20 holes of a part of the bone anatomically, which is called cribriform plate of ethmoid. After that, they go to primary order of the nerve, then they go to glomerulus, and from glomerulus they go to second order nerve of epithelium, nerve of the neuroepithelium, which is called secondary order, and they create a tract, they go through the central nervous system. They reside in an area which is called olfactory cortex, which is located through the thalamus and also through the amygdala. This is a picture which we can summarize. Olfactory receptor cells located in neuroepithelium lining, which is upper end of the nasal cavity. They pass through the nasal cribriform plate of ethmoid. They come to glomerulus. After that, they go second order of neuron. Finally, they create a tract, which they go to thalamus plus amygdala regions. And the person can feel the sense of a smell. This is a central part, which is olfactory neuroepithelium, cribriform plate of ethmoid, olfactory nerve, goes through the thalamus plus amygdala region, which is called primary olfactory cortex. The reason that I bring this point, because those people who are doing the surgery, they must be very cautious not to reach these areas. Of course, rhinoplasty, especially open part, the surgeon can see every part of the nose, cannot impede or penetrate through other parts of the patient's anatomy. But however, it's nice to understand the surgical anatomy of this system. Olfactory epithelium, as I said, is upper end of nasal cavity. Olfactory nerve has special afferent smells, 15 to 20 pairs, passing through the cribriform plate of ethmoid. Olfactory nerve cells pass through the cribriform plate of ethmoid bone, and they create that glomerulus and afferent sensory tracts toward the cortex. We do rhinoplasty up to here. We are not going to touch the frontal bone, frontal sinus, or even the anterior part of the cranial fossa, which is the olfactory bulb are located. We are just working in this area. Well, if we look at it much more close in the lateral wall, also if this is an olfactory mucosa here, we do the rhinoplasty in the front part of the nose, in the front part of this room, not the end of the room or upper part. We're just working in this area, which is that frontal bone, frontal sinus, olfactory bulb, sphenoid sinus, and lateral wall of the nose, which is turbinate, superior, middle, inferior. We are working in this area mostly, unless we do work some septoplasty, which we go over the septum. That is different. That makes more chance of smelling loss for the patient, which I'm going to get to it in a minute. These are the map of the MRI, which shows the brain orbits, nasal septum, turbinate, superior, middle, inferior, nasal septum, which is here, and also these two are olfactory bulb, and the tract which emerges from the olfactory bulb goes to the central nervous system. I made an experience, as I said a few minutes ago, clinical is experience, is empiric. I just made a correlation with the inner canthus of the eye. Every patient comes to me, I do not touch or do not cut or not manipulate those organs from this area and lower, because that is create trauma and damage to the olfactory tract. Surgeons should not only know the clinical anatomy and have experience, have seen all the exposure with the field of plastic surgery and plastic surgery in the nose, everything, but must check one thing which is important, so important for my young colleagues who are sitting here, probably you're coming just from medical schools anyway. Always ask history. Any patients who come to us, we should ask the history pertaining to that problem. Have you had any smelling loss? Sometimes the people having a smelling loss because of genetic basis, and we don't know it. We should ask this. Do you have hyposmia, or relatively compared to other people, do you smell less? Have you done any surgery in your nose? Have you done any operations for any other reasons? Have you had any trauma? Have you had any diseases in vicinity of this area? Sinusitis? Are you taking any medications? My colleague who came said just heart rate would be eliminated. If we elevate it, we can decide to do the fistulas diagnosis. Sometimes people are taking medications, and that causes some smelling loss. We should ask any medications, any narcotics, not in my country, but in North America. I'm faced with many patients who come to smelling loss, but when you do the examination, you see a big perforation in the septal area because of narcotics, cocaine consumptions, and medical consumptions can cause great septal perforation and induces that perforation from the nerve ending of the olfactory nerve, and that also creates a smelling loss. Physical exam is very important. You can see the front part of the septum, turbinate, crowne, and mucosa. See the color, see the discolorations. See this patch of the coloration. Sometimes the color is not unified. See the discrepancy between right and left. See the septal deviation. Sometimes vomer is so big and crowne is so closed that patients cannot breathe easy, plus the patient cannot smell correctly. So these are the examinations that we can do as a clinical tools to estimate what the patient has regarding to the olfactory loss. Paraclinics, complete blood assays, plus some of the tests are pertaining any diseases in vicinity of the nose, which is computerized tomography, spiral type. You can see all the sinuses, contouring. If you're questioning some soft tissue lesions, such as tumors around here, you can do MRI, which that also helps you that the patient suffering from smelling loss probably is due to some tumors. Surgically adopt a test to do the smelling test in the state of ambiguity. When you're not uncertain about the smelling function or smelling factor preoperatively, do this examination. It's called SIT, or Smell Identification Test. I adopted this test from University of Pittsburgh. They have adopted a booklet. They have 40 odors, which is culturally familiar for that vicinity with them. They have done this test. In my culture also, I collected 40 odors, which are familiar for my population, for sampling of my patients. That's why this smelling identification test must be culturally based. Some of the things which does not exist in another culture, they don't know what it is, so they cannot tell you the smell, if it exists or not. Post-surgical inflammation occurs, no matter how delicate you do the surgery, because this trauma, especially in our case, doing osteotomy, especially medial osteotomy of the nose, lateral, plus low to high lateral osteotomies create some trauma to the cribriform plate of ethmoid. It might create some microfractures in this area. And that passage of the nerve ending, which as I just mentioned, passing through the cribriform plate of ethmoid, that creates a neuropraxic condition for the smelling factor. That's why the patients might not be traumatized in the nerve endings over there, but indirectly creates a trauma because of our surgical trauma. Bleedings, also that create some swelling over there. And as I said, that patient doesn't have pain because the olfactory nerve is not a nociceptor by nature, is a chemotaxic by nature. That means creates some sensations by some chemical substance, which is the odor spray or something. These creates the edema, that algorithm which we used to say in medical school so many years ago. It's rubor, tumor, calor, dolor. Rubor, redness, tumor, swelling, and C color, heatness, hotness, and D dolor, pain. But this one doesn't have any pain. Function less, gets functionally less. Actually, this is what happens in olfactory nerve during the surgery. When that happens, the patient doesn't have any smelling, and that creates worriness about that patient. Continuously ask us why, when, am I going to return it? Am I going to lose it? Why? As it says, we do have so many good things in our life. We cannot appreciate it unless we lose it. Those people who are losing the smelling is like those people who can see, but they are not appreciating their sights. But when they lose it, they just get worried and ask you questions. When, why? That's why colleague and I, we decided to create a study. The study was cohort. We cannot do it control, of course. Clinically trial, we just did it cohort. That means from now on, we decided to collect 65 patients. Out of 65 patients, we chose 40 patients based upon exclusion criteria. And we did all of them matched as much as we could: gender, health status, systemic diseases, taking medication, not taking medication, any problem that they had, to reduce the bias in our study. And we did open rhinoplasty with one technique, one surgeon. We did test SIT with the same colleagues that they helped us during the study. Preoperatively, we did a test with 40 bottles of familiar odors. Some of the odors were familiar internationally, such as rose, everybody knows, onion, spearmint or mint, or eucalyptus. These are the medications probably everybody is international, but there are some odors and spices which belongs to our country. That's why we chose those. We did preoperatively, we did SIT, spelling identification test. We did the open rhinoplasty. And after open rhinoplasty, 1 week, 3 weeks, and 6 weeks, we assayed the function, how it returns. And SIT test was like this: 40 bottles with familiar odor. We shook it and put it in sniffing mechanism with the patient, correlated and performed with the same technicians. These are the 40 odors, spices, which are familiar. After we did preoperatively, more than 90% SIT test was normal. But after the operations, most of the patients lost their smelling functions after 1 week. 87.5% patient after 1 week, they lost their smelling. And after 6 weeks, 2.5% they lost. That means the edema is subsiding. Gradually, the patient is going to return their smelling mechanism. And after 6 months, eventually 90% of the patients who had preoperatively loss of smelling, their smelling functions, they return. And this is a curve that shows first preoperatively, post of 1 week, 6 weeks, and 6 months, with everything is regressing and evolving. The conclusion is, the message of this paper, of this presentation, is the temporary decline in the olfactory function following open rhinoplasty can be expected to fully resolve by post-operative 6 months. I want to appreciate the omics collaborative individuals who helped me to present the paper, and chairpersons for giving the opportunity to talk with you. Thank you so much and have a great one. If any questions come up.
Thank you, Dr. Hashem. Thank you so much. Any questions?
Thank you, sir, for a wonderful paper. I'm Derek Mendonça. Do you compare olfactory function in those patients who've had an osteotomy versus no osteotomy?
No.
Did you think there was a difference in
No, we
osteotomies?
just, in order to reduce our bias, we did the same technique, and those people who needed osteotomies, medial, lateral, and low to high, we matched it because we wanted to reduce the trauma, the degree of trauma. You're right, that's a good question, because sometimes people do not need any osteotomy. That means the trauma is much less. So the olfactory function might return much sooner. No, we checked that, so we did the same operation, the same technique, the same trauma, as much as we could. But research, you cannot eliminate all the biases. Some people say, oh, these patients had lunch before operations, had big lunch. The other one had a less lunch. Really, it's very hard in research, especially cohort. You have to follow everything, so it's difficult.
Thank you.
Any question?
Any more questions?
I want to ask you what the type of osteotomy, to do percutaneous osteotomy or transmucosal?
To cross mucosa?
I think it will, is any difference in the olfactory function you comparing percutaneous osteotomy or transmucosal osteotomy?
No, we have not comparing it, because probably in future we do some group as a control, the other one as non-group. But this one, as I said, our limitation was the access of the patient that we had in our hand. We wanted to make it even. That's a good question. In future, maybe I can do a clinical trial, make a control. Thank you for asking the question.
Thank you.
Thank you.
Thank you. And any more questions? I've got a question, Dr. Shemshadi.
Yes, sure.
Is your conclusion consistent with other literature data on postoperative smell loss?
That's a good question, doctor, because when I faced with so many questions of the patient, when, I did the literature. If you go home today and do a review literature, probably one of the paper that gives the timing, one of the few, very few literature I couldn't find. If I could find, probably I wouldn't do this research. Oh, I was not able to find the exact time. Really, we wanted to make a tabulation time for the patient, saying 1 week, 6 weeks, or 6 months, this will return. However, some patients are impatient. They're asking you when, because I have go to wedding, I want to smell something good, but I'm in a hurry. Yeah, that's a good question, bro.
Yeah, not clear.
Literature, very scant, very few, not too many.
Thank you. Any more questions from the audience? It was very interesting. Thank you very much.
Thank you very much. Thank you for
You may
listening
join
to
us
me.
in here.
Thank you for your time.